global webinar and
This meeting is being recorded.
on the fifth global webinar on traditional and integrative medicine. My report is called Unrecognized Human Dermatosis and its frequent clinical masks. In medicine, the existence of human dermatosis as a holistic disease is still under debate. Although Demodex mite was discovered 181 years ago, but until now, the question about its role in human is unresolved. The views of researchers vary from inoculous, saprophyte, and conditionally pathogenic agent to causative organism of demodectic blepharoconjunctivitis, discoid lupus erythematosus, and acne rosacea. In veterinary, Demodex is unequivocally considered a pathogenic microorganism. Morphology and biology of this mite is fairly well studied. Like any mite, Demodex possesses tremendous adaptability. Body build of this mite allows it to move on any surface in any tissue. A complex piercing, cutting, sucking, and gnawing mouthpart allows it to feed on different nutrition. Glandular tissue is a favorite place for the localization of this mite. Demodex is pressed through the surface of its body.
This meeting is being recorded.
It feeds on different nutrition. Glandular tissue is a favorite place for the localization of this mite. Demodex is breathed through the surface of its body, but there is information that some of its representatives have shifted to anaerobic type of respiration. Acarologists have established that Demodexes form colonies inhabited by them skin glands, while in glandular tissue, they form Krolikovsky's spherulas. Demodex mites are found in the skin of practically almost all people. Many researchers found Demodexes in human body excretions, saliva, tear, fluid, sputum, bile, feces, etc. Demodexes were found along glandular tissue that lines the bed of nerve fibers and in soft nasal tissue. There are reports where Demodexes were found in lymph vessels and nodes, in spleen and liver. Presence of antibodies to components of Demodex's body was detected in the blood of patients with demodectic blepharoconjunctivitis. But in medicine, demodicosis is unstudied and undescribed in a holistic form. The random factor has played an important role in the history of my serious scientific discoveries. The given work began with a random fact. From the lesion on the face of inpatient woman, huge numbers of demodexes were coming out. According to the consultant dermatologists, the patient was considered harmless to others. However, by me was not convinced with such a response. This doubt served as the reason for careful observation of the skin of all people directly on and indirectly contacting with that patient. In that period of time, most of people had healthy skin. Against the background of healthy skin, subtle changes that began to be observed in people who had contact with this patient were visible. The changes revealed never completely disappeared, but only progressed over time. Given initially healthy skin, 6 years later, there were 342 persons with primary skin lesions by demodexes. Changes caused by demodexes eventually underwent characteristic changes. This became a reason for careful examination of the skin of all people around colleagues, visitors to the hospital, acquaintances, people in public places, speakers on TV screens, etc. In patients with chronic hepatitis also had similar changes of skin. In order to find confirmation of my etiology of those changes, when concomitant pruritus present, we began to assign external anti-mite ex-evangelist treatment to a group of 186 supervised patients. At the same time, a similar group was observed of 131 people who did not receive such treatment. Ultimately, skin condition improved sooner and for a longer period in the patients who received an anti-mite therapy. This result confirms the mite nature of the symptoms described and evidenced the existence of a caused by mite disease not considered by clinical medicine. With apparent high level of medical science and technology, existence of an unrecognized infection disease among the population seemed implausible. This fact led to undertake a clinical experiment on August 10, 1980, auto-infestation with pneumococcosis. Successful clinical experiment dispelled all doubts. In 1981, I conducted a mass examination of the skin of people in organized collective colleagues, hospitals, working collective schools, kindergartens, etc. To the members of the Commission of the Ministry of Health, I demonstrated colonies of demodexis, which were isolated from indicated by me specific pathological elements of the skin of allergic and dermatologic patients. I considered a mass examination of residents and tourists of Almaty. On the 8th month of the clinical experiment, an extremely severe allergic reaction developed, manifested by deep red color of the entire skin cover, skin edema, the emergence of bubbles, scattered bright pink papules, ulcers, and oozing lesions in the skin folds. However, that inoculated dermatitis was not correctly recognized by the dermatologists, but was diagnosed as erythrodermia and generalized neurodermatitis, despite the anamnesis. To double-check raised doubts about the contagiousness of the process, material collected from the skin of the subject was applied on the skin of 2 prepared kittens. As a result, a typical dermatectic lesion appeared on the snouts of both kittens. Together with acarologist Kusov, doctor of biology, in 1993 to 1997, at the premises of the scientific medical small enterprise Saule, the comprehensive work was conducted, which included acarological examination of treated patients and their biotope with species identification of detected mites. When necessary, clinical, biochemical, immunological, instrumental, and acarological studies were conducted in admitted patients. During 48 years, a total of 43,198 patients sought treatment. Previously, they had been unsuccessfully treated in different medical institutions or by healers. Before applying to us, 57.7% of patients had allergologic, 37.4% dermatologic, others have ophthalmologic, rheumatologic, oncologic, gynecologic, endocrinological, surgical, urological, psychiatric diagnosis. Only 0.4% patients applied without any diagnosis. A 2-year follow-up to 8,712 patients was organized after the course of anti-dermatitis etiopathogenetic treatment. Among them, there were 1,666 patients with allergy and 3,460 patients with allergic dermatosis. Before applying, do you listen me, colleagues?
Yes, Dr. Alexa, we hear it.
Thank
Yes,
you.
we are listening to you.
It's very silent, and
Yes, yes, we are listening to you.
Among them, there were 1,666 patients with allergy and 3,460 patients with allergic dermatosis. Before applying to us, they had received treatment for food or drug allergy patients, 763 patients, allergic blepharic conjunctivitis, allergic perennial rhinitis, pollinosis, asthmatic bronchitis, executive diathesis, acute urticaria, chronic recurrent urticaria, eczema, neurodermatitis, generalized dermatitis, focal dermatitis, contact dermatitis, psoriasis, parapsoriasis, discoid lupus erythematosus, photodermatosis, 43 patients. A total of 17,823 persons were subjected to acarological examination. The Demodexes were found in 98.9%. In 1.9%, mites were not found. In 0.5%, Demodexes plus dermatophagitis were detected. In 80%, Demodexes plus Sarcoptes scabiei. In 2.4%, Demodexes plus dermatophagitis plus Sarcoptes scabiei. In 18% with healthy skin, none of the available diagnostic methods could isolate mites from the skin. Colonies of Demodexes were found in populace of 242 patients, in the acneiform item of 247, atheromas of 18, and in chalasia of 12 patients. In the biotope of 412 patients, solely dermatophagitis were detected, but only Demodexes were isolated from their skin. Six years later, 342 persons with healthy skin had affected by demodicosis skin. They had direct or indirect contact with the patients with discoid lupus erythematosus. Demodicosis gradually developed in them at different rates and with different onset. A focused examination of the skin of often parts of the body was conducted by me for many years. In 1981, every month, the number of people with signs of skin lesions caused by Demodexes grew, while with the number of people with healthy skin of often parts of the body intensively decreased. Starting from September 1981, people with healthy skin were no longer met. In subsequent years, with the same purpose, continued examination of the skin of the open parts of the body of residents of visited to 26 cities in Europe and Asia. In total, skin of the open parts of the body of over 3 million people was examined. As a result of anti-mite treatment ex evangibus, in the main group, skin itching disappeared earlier than in control group. 2 months later, itchy skin was absent in almost all patients of the main group and only in 30% of the control group. Skin condition looked better than in patients in the control group. Successful clinical experiment, self-infestation with demodicosis, ultimately strengthened confidence in the reliability of the observations. Inoculated demodicosis took generalized manifestation. Therefore, in March 1981, treatment was initiated. Regular schemes of treatment of classical scabies did not fit. It was necessary to elaborate treatment of the demodectic type of itch. Through trial and error, only by mid-1986, I managed to achieve full recovery from inoculated demodicosis. 92% of 43,198 admitted had positive outcome after the anti-dermatotic treatment. 70% patients with allergic dermatosis and 95% of patients with allergy completely recovered as a result of the pathogenetic treatment. Patients were followed up for 2 years after the treatment. There was no disease recurrence during the follow-up period. The results of treatment suggest that in the specified percentage of cases, allergy were clinical masks of dermatitis. Unfortunately, from year to year, the number of patients with more severe clinical masks of dermatitis increased. Aggravation of the cause of dermatitis affected results and the times scales of treatment. So in 1991, maximum 1 month was sufficient for complete recovery of patients. In 2006, at least 6 months were required. In 1981, I am clinically identified dermatitis in 96% of 388,780 examined. Results of studies indicate that dermatitis might in humans definitely cause a primary chronic invasive disease, dermatitis. Infection with dermatitis occurs through direct and indirect contact with the source of invasion. In early 1970s, there were many people with healthy skin, and inoculation of even one mite in healthy skin was visually noticeable. Trial anti-mite treatment, which provided improvement of the patient's condition, allowed to understand the correctness of conducted observations. The positive clinical experiment even more strengthened this belief. That consultative examination of inoculated dermatitis in April 1981 was the starting point for us for further scrutiny of the interrelation between dermatitis and allergy. When conducted treatment eliminates the cause of the disease, the results do not make us wait. We were receiving amazing results because of the introduction of our theoretical developments in the treatment. For instance, the worker who had been incapacitated for 3 months and was admitted to the hospital of the dermatovenerology dispensary at once returned to work after 3 etiopathogenetic treatment procedures performed by us. Young woman which had hay fever and suffocation and due to illness had previously relocated to another country, was fully cured and returned to the original place of residence during the guilty season. An elderly woman with discoid lupus erythematosus was cured to the state of infant skin of the face. An old woman barely moving around the apartment due to chronic trophic ulcers, fully cured, and then began to provide medical assistance to patients like her. After our treatment, no problems remained in a woman with the forehead skin cancer, due to which oncologists had previously recommended her to change job, and she continued to work as a trolleybus driver. There were many such cases. The striking results were due to the fact that in all of those cases, the patients received etiopathogenetic treatment. In 92% of admitted patients, recovery came from conducted antidemodexic etiopathogenetic treatment. This fact suggests that in the specified percentage listed diseases were clinical masks of unrecognized demodicosis. That is why antidemodic treatment led to recovery. Since demodexis inoculates through the skin, it is not surprising that primarily changes occur exactly on the skin. Moreover, the telltale signs of lesions were visible only on the originally healthy skin. Reported by allergists at the dawn of allergology, fact of predominant affection by allergy of the skin and visible mucous membranes also counts in favor of demodicosis, since infestation with demodexis takes place through the skin and the mucous membranes communicating with external environment. Why did allergy complication primarily develop in the experimentally reproduced demodicosis? Firstly, the emergence of allergies in human body affected by mites is quite predictable fact. Components and the discharges of any mites are alien to the human body. That is, are allergens. This is an axiom. An immunocompetent organism generates antibodies to allergens. This is also an axiom. Anti-mite remedies used in the subject patient resulted in a mass death of mites that lived in the skin. At this, a huge amount of mite allergens discharged, a reaction well described by immunologists of connection of antigens with antibodies developed. Full cure, 17 to 95% of patients with allergological diagnosis after conducted anti-mite treatment testifies that the leading causative factor of allergens in those patients were mites. Could the discoveries that recount demodexis among saprophytes microorganisms of human skin be wrong? There might be a two-fold opinion. Possibly 181 years ago, demodexis were indeed saprophytes of human skin. However, according to the laws of biology, too long-lasting symbiosis after such a long period of time would morph first into ecto and subsequently into endoparasitic mode of life. In favor of the latter opinion is the statement of allergic reactions in allergological patients, not only from part of the skin and the mucosa communicating with ambient environment, but also from part of internal organs. Unfortunately, clinical observations indicate that demodexis freely live in the internal organs and tissues of affected people. Patients feel it, and we must believe them. On the other hand, scabiologists have confirmed the existence of a residual acarologic itching in patients treated from the classic scabies. It could be due to remaining in the body of patients demodexis and dermatophagiosis, which as is reported by all authors of studies on classic scabies, always accompany Sarcoptes scabiei. According to the laws of biology, a remaining demodexis in the complete absence of natural antagonists of the microorganism, Sarcoptes, lices, fleas, bedbugs, etc., could have gradually occupied all the ecological niches in the human body. Judging by the actual observations, indication by some authors at favorite localizations of demodexis is incorrect. Demodex inhabits glands at all sides of the body. If there is the modex in one side, then it's usually present in pores of all the other parts of the skin, covering and mucous membranes, communicating with external environment. The only question is its number, virulence, host status, and several other factors. Currently, allergy is prevalent everywhere. It turned out to be the earliest and most frequent clinical mask of dermatitis. Therefore, it is appropriate to speak about a pandemic spreading of dermatitis, all the more so because, according to acarologists, the modex mite is found in 100% of cases among residents of all continents. Due to the lack of diagnosis and proper fight, dermatitis is present in the form of various clinical masks, which are the object of treatment by physicians virtually of all clinical specialties, far from being fully listed in the analysis of diagnosis of admitted patients. Therefore, the elimination of dermatitis may provide recovery from its various clinical masks, primarily from allergies, but for liquidation of dermatitis through knowledge of its clinical picture by all clinician doctors is required. Mankind is not in vain concerned about the aggravation of the cause of allergies and the growing diversity of its manifestations. It is precisely because of the lack of diagnosis of dermatitis that all diagnosed so-called non-communicable diseases of a person cannot be completely cured. Large dermatitis already affects the internal organs and tissues. In conclusion, I want to say that the reliability of the results of my research is indisputable, which is why I am so persistent in my appeals. I can prove the correctness of my scientific positions by demonstrating a complete cure for various clinical masks of dermatitis, from which I have repeatedly carried out a complete cure of 41 years. The list of diagnoses among which patients can be selected for a complete cure as a result of anti-dermatitis treatment. Hay fever, perennial rhinitis, allergic rhinitis, atopic dermatitis, allergic dermatitis, food or drug allergy, jewelry allergy, insect allergy, contact dermatitis, perioral dermatitis, diathesis, rosacea, acne, rhinophyma, neurodermatitis, psoriasis, parapsoriasis, eczema, skin itching, furunculosis, discoid lupus erythematosus, alopecia, erythroderma, photodermatosis, Raynaud's syndrome, chronic urticaria, xanthomatosis, skin precancer, skin cancer, dry skin, vulval leukoplakia, vulval sclerosis, flaccid skin syndrome, initial stage of vitiligo, trophic ulcer of the leg, pruritus, demodectic blepharoconjunctivitis, the initial stage of systemic lupus erythematosus. Perhaps there are many other diagnoses that can also be clinical masks of dermatitis. Dear colleagues, in conclusion, I want to say that neglected human dermatitis was currently spreading pandemically. Its main clinical masks Its main clinical masks are skin changes, allergy, and non-communicable diseases that you will work with. It is required to prove dermatitis lesion of various internal organs. There are already publications about allergies of internal organs, cases of congenital allergies, about allergies to one's own child. I found the description of the methodology for searching mites dermatitis in human tissues and organs in a textbook for medical schools on pathological anatomy. Taking into account the colossal natural adaptability of mites, it must be assumed that these insects can change the color of the body when living in internal organs and tissues. Each of you helping to improve the health of people who come to you is faced with one or another clinical mask of the currently widespread human dermatitis. To verify this, you can search for mites and their colonies in the organs, tissues, secretions of the mouth, nose, eyes, skin, glands, and mucous membranes of people who come to you with a variety of diagnoses. And you will be convinced that the true deliverance of these patients from mites, along with the correction of impaired functions of organs and systems, will ensure a complete recovery. If necessary, I am ready to provide all possible assistance in the diagnosis, treatment, and prevention of human dermatitis and its complications. Thanks for attention. And dear colleagues, please kindly ask me questions in writing